here like you wanna be someone else.
Hi everyone, it's 3:30 p.m. and we are going to turn on the live stream for online participants in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hi everyone, welcome back to session 4 of SHBC 2022. I am Dr. Ang Renxuan, Senior Resident with the Department of Geriatric Psychiatry at Institute of Mental Health, and I'm your MC for session 4. For our online participants who have just logged on, a warm welcome to you. We invite you to send in your questions through the Q&A tab that you see at the top of your screen. For our on-site audience, once again, please feel free to scan the QR code that you see on your table stand. Please keep the questions coming, and the panelists will try their best to answer them. I would now like to introduce to you the fourth and last plenary speaker for today. We have Professor Sir Aziz Sheikh. He is the Professor of Primary Care Research and Development, Director of the Usher Institute, and Dean of Data, University of Edinburgh. He is also Director of the ESMA UK Centre for Applied Research and Director of the Health Data Research UK Breathe Hub. Prof. Sir Aziz holds a number of visiting chairs, namely University of Birmingham, UK, Queen Mary's University of London, UK, and Maastricht University, Netherlands. He was previously Visiting Professor of Medicine at Harvard Medical School. He is also an editorial board member of BMC Medicine, Health Informatics Journal, Journal of the Royal Society of Medicine, Medical Care, and PLOS Medicine, and is the editor-in-chief of the International Journal of Quality in Healthcare. Prof. Sir Aziz was also made an officer of the Order of the British Empire for services to medicine and healthcare in 2014, and Knight Bachelor in 2022 for services to COVID-19 research and policy by the late Her Majesty Queen Elizabeth II. Let us put our hands together to welcome Prof. Sir Aziz on stage. He will be sharing with us the plenary topic of Partnership for a Sustainable Care. Prof. Sir Aziz Sheikh, please.
Great. Well, thank you very much indeed for those kind words of introduction. It's absolutely fantastic to be back in Singapore after a few years and really enjoying the meeting here today. So thank you so much for the invite. So I've been asked to share a few reflections from the UK in terms of our journey in towards developing sustainable healthcare partnerships. And what I'll try and do is just provide this as honestly as possible. I mean, I think there are some things that are working very well. There are other areas that remain works in progress. Just in view of, I wanted to share my disclosures with you at the outset. These are largely governmental roles. As you can see, they're pretty COVID heavy, but I don't think they have any particular bearing on what I'm about to say today. So what I wanted to do was provide a bit of context to begin with, and so to describe the UK's national health services, and I'll explain why I say that in the plural. I want to talk about some of the kind of political aspirations and policy goals around the reform agenda, particularly over the last decade. So explain some of these that have taken place, and what I will do in doing so is focus very much on England, sort of the major UK nation. I want to then try and reflect on what the evaluations that have been done so far are showing in that respect. And then finally, just share with you some thoughts that have come from a major commission, the Lancet Commission, on the future of the NHS. And I hope, what we'll be able to do in the panel discussion is try and tease out some of the implications for Singapore as you embark on this, I think, really interesting journey towards healthier Singapore. So in terms of the National Health Service, I think it's an absolutely fantastic institution. It was born in the aftermath of the Second World War, 1948, and it was part of the Labour government's agenda to really address very major issues confronting British society at the time. So this was really around tackling the five giants, as they were described. So idleness, want, disease, and that's what gave rise to the NHS, ignorance and squalor. And really, I think it was Nye Bevan, the minister at the time, who, I think really encapsulated this absolutely wonderfully, that one of the hallmarks of a civilized society is that everybody has a basic right to healthcare. So that's what was enacted back in 1948, and it remains really, I think in many respects, a kind of a bellwether for public services. It remains, I think, very, very close to British hearts. What we have had subsequently is that health has become a devolved nation. So the UK is made up of 4 countries. Back in 1999, health was devolved. But really, even though it's devolved, essentially, the core ingredients remain the same. That this is funded through general taxation. And we have, differential taxation policies in the UK and Singapore, and that's something that we may want to pick up on in the discussion. Free at the point of care, it's comprehensive with very few exceptions. I think the most pertinent one being a co-payment for prescriptions. Maybe just a kind of a note here, in the devolved nations, prescriptions are free of charge. So it's only in England that there's a co-payment model. Really, the vast majority of people will be dealt with almost exclusively within the NHS. Private care remains very, very peripheral. And primary care is really the coordinator and gatekeeper. So every citizen is impaneled or registered, as we would describe it in the UK, with a general practitioner. The general practitioner is the coordinator of care, and so any subsequent referrals to secondary or tertiary care have to take place via the general practitioner. There is no direct access to specialist care in effect. I think it's kind of a historical legacy issue is that primary care practitioners remain sort of independent contractors within the NHS, so they are largely private businesses. There are some emerging as salaried GPs, but the vast majority remain independent contractors. So this schematic really sort of summarises the NHS and what is in scope, and really what the NHS is trying to move to as far as possible is a patient-centred model of care. I think just like as you guys are trying to do here, that is, increasingly important as we move to dealing primarily with people living with long-term conditions. So what we need is sort of coordination. We need longitudinal models of care rather than the kind of episodic models of care that were important when the NHS was founded, when it was predominantly dealing with infectious disorders. And so the NHS, has to evolve, and sort of what are the kind of aims there? I think that, you will recognise, many of these. So there's a triple aim as kind of sometimes formulated by the Institute of Healthcare Improvement that resonates with our governments in the UK. So the triple aim of trying to improve quality, safety, efficiency, and trying to do that, simultaneously. What we want to see is increased life expectancy and also healthy life expectancy. We've been hearing about this this morning. We have a very strong focus on reducing variations and particularly inequalities of care. It is very socially patterned healthcare utilisation and outcomes, unfortunately, and so there's a very strong drive towards that. And long-term sustainability, and what that really means is around somehow trying to bend the cost curve for the NHS, because this is a publicly funded entity. Well, how does that translate into sort of policies that are enacted? Increasingly, a focus on prevention, longitudinal models of care, moving care out from hospitals into the community, and this is largely through GPs, but also then working in partnership, and we'll come on to some of that in a few minutes. Emphasising the role of individuals, because if we are living with long-term conditions and multiples of these, then even if you are seeing your GP 3 or 4 times a year, the vast majority of the care you are self-providing, and so expertise, understanding, ownership, responsibility become very important. A lot of policies trying to reduce health inequalities, and really very much around the integration journey. Integration across healthcare providers, but also increasingly the focus is with social care provision as well. The NHS is probably the closest thing in the UK to a religion other than football. And I mean, I think we're going to be having a kind of a religious festival coming up. I've just come back from Doha. I mean, I think they're very excited. But sometimes in the UK, this is described as a sacred cow. I mean, everybody has to kind of get involved, I mean, whichever political government is in place. But I mean, you can only sort of meddle with this to a limited extent, really. I mean, it's kind of a very delicate area. So there is reform needed, but this needs to take place bearing in mind sort of public sentiments. So key recent reform initiatives. I mean, I think the context for this is that, unlike you guys, I mean, we unfortunately have a lot of political instability at the moment, and what we have is this is a pretty major proportion of our spend of GDP, and so I mean it is very political. And as you can see over the last decade or so, and that's what I'm going to focus on, we've had 4 leaders, and who knows, we may have a 5th before the decade is out, but let's see. In terms of, I mean, you had your Minister of Health and you've had stability in that respect. And what we've had is, I mean, a number of Secretaries of State for Health over that intervening period. And I think the reason this is important is because typically when there are new Secretaries of State, we have new changes of plans. And as you can see, I mean, looking at this timeline, there isn't very much time really to see whether, I mean, you can actually implement things and make a difference. But these are the kind of major reform initiatives that have taken place over this last decade, and I'll talk through each of these briefly. So the first of these was the Health and Social Care Act of 2012, and it was brought in by the Conservative Liberal Democrat coalition government. It was really, I mean, a very far-reaching change, and what it did was it kind of removed overall responsibility for health and health outcomes and health delivery from the Secretary of State, from the Minister, to a new entity that was created, NHS England. What we had was, I mean, grouping of primary care providers, primary care trusts, and sort of more regional I mean, health alliances, strategic health authorities. Those were removed, and what was introduced was something called care commissioning groups. And so really this was very much a model built around primary care trying to be put into the driving seat, but competitive tendering processes around then who would provide that care. So it was really, I mean, a very much in keeping with our Conservative government's ethos, a competitive model, I mean, a market-based approach. A lot of regulatory mechanisms introduced, and in particular the Care Quality Commission. Understandably, there were very major concerns from professional bodies and patient groups around this very top-down initiative. And an initial evaluation 3 years into this showed that what this resulted in was a lot of frustration, I mean, major reorganization, a lot of energy spent on that, marketization, complexity being introduced, and no clear understanding of, I mean, where leadership and accountability, I mean, ultimately stood. The next thing that came in was sustainability and transformation plans, or as they were subsequently renamed as partnerships, and this came in from around 2016. And then the idea was really to try and move away from this competitive model that wasn't working to something more collaborative, working across geographical footprints. And again, I mean, hopefully some of this is kind of resonating with what you're hearing. So these were very much place-based initiatives, and I mean new models of care, quality improvement, focusing on sort of health outcome transformation, efficiency, and there were a number of these created, I mean, across England, with reasonable kind of footprint prizes, an average of 1.2 million people being sort of taken on within each of these STPs. The initial evaluation of this showed that there was little in the way of demonstrable impacts overall. And I mean, the reasoning for this was that, I mean, this was really very much based on MOUs, or memorandums of understanding. The underpinning legislation didn't change, or that was the kind of, I mean, core reading at the time as to why these things were kind of struggling to deliver. What also remained was, because legislation didn't change, although now there was trying to promote an ethos of partnership underpinning all of this, those competitive structures remained. So the next thing that was created was the NHS long-term plan. So this was 2019. So this was a 10-year plan that was put together to try and put the NHS onto a better footing. At the time, this is obviously sort of pre-pandemic. There was a kind of a, quite a big sort of financial challenges arising. Kind of an official abandonment of the sort of competitive approach, legislative changes, because that was a concern that was previously being articulated, and really very much a kind of a wholesale shift to try and move care into primary care contexts. There were key priorities identified, some of these centrally, and these are kind of big ticket pandemics, in inverted commas, that not only we in the UK, but I think every sort of economically developed country is facing, but also the opportunities for local priorities. And on the back of this, there was really, an uplift of funding that was due to be put into place from next year. What then has subsequently happened is that work has been taken forward into what's known as integrated care systems. So this has been sort of a kind of a formal transition, really, again, working across geographical boundaries, working, particularly trying to develop partnerships between healthcare providers and social care providers working in local communities. This time responsible for, patches of between 500,000 and 3 million people. A number of core metrics agreed, that are kind of centrally reported, but also some local metrics that can be also agreed and prioritised. It's very early days, but recent evaluations of this are showing that at the moment, overall across the piece, there is relatively little in the way of kind of tangible improvements being seen. There are some pockets where, there are changes being seen, and maybe we can pick up on some of that in the discussion as to what some of the ingredients there might be. But overall, I think frustration being highlighted because of the funding still hasn't followed, so reorganisation, but the funding flows haven't substantively changed. Social care's come into the mix, but no sort of additional funding brought in to sort of pay for that. And really what there remains is that, GPs are continuing to be paid on a per capitation basis, hospitals on the kind of an activity basis. So again, there hasn't been that financial alignment, and I think, again, some of that we were discussing this morning. What do you do when you're kind of trying to think about this at a kind of a meta level? What's happening across the country? So what we look at sort of life expectancy over this time period, because this is one of the things that government is looking at. I think your government will also be looking at this. What we're seeing is, you can see the UK there, at the bottom of that pile when we're looking at sort of comparable nations. Certainly we're not seeing any improvements, and if anything, we're seeing a bit of a deterioration, unfortunately. Some of this is because of kind of complete mismanagement of COVID, unfortunately. If we want to bend cost curves, then reducing hospital admissions is absolutely fundamental to all of this. Again, despite this decade of, busy activity, a lot of reforms, a lot of reorganisation, at the moment there's no signs of hospital admissions decreasing. When we look at costs, over that period and cost projections, costs are, there's no signs of, unfortunately, any attenuation. If we look at, this comes from the Commonwealth Fund, their Man in the Mirror, they produce this every couple of years, looking at, across 11 high-income countries. What we see is, the UK previously was number one in all of this in terms of efficiency. It's always struggled with the outcomes. But what we're seeing is that, unfortunately, sort of countries are overtaking. So these reforms at the moment are kind of not having sort of the desirable impact. A report recently that's come out from the Nuffield Trust, a major policy think tank in the UK, saying that sort of 4 key lessons from all of this: that structural reform is important, but it's insufficient. What you have to do is think about integration, and integration is fundamentally about relationships. So structures are, of course, important, but that's not a substitute for relationships. Thinking about how you do that, across organisations, and that's hard work. It takes time. Legislation, is of course important, but again, not going to be sufficient. Need to be realistic around timeframes for all of this. This will take, I think, considerable time. And I've just been asking, colleagues, what kind of time horizons are you working with for your healthier SG initiatives? And having the data in place to actually be able to measure what you're doing and do this not only in summative ways but formative ways is incredibly important, because at least you can see whether you're on the right track or not. So what we have is, an absolutely fantastic institution that is unfortunately struggling, and because of, these kind of range of reforms, and reforms each time are kind of heavy lifts. Unfortunately, what we've also got is a pretty burnt-out workforce. They've had a torrid time during the pandemic, but predating that, unfortunately. So, I think this is very, very challenging circumstances. So maybe just in the kind of last few minutes, I was privileged to be part of this Lancet Commission on the Future of the NHS that reported, just last year. And there are kind of a few key things that we highlight here. And so what we do need is, what we're proposing is a 4% uplift in investment year on year, at least for the next decade, to try and get the NHS and social care back onto a sort of an even footing, because there's been underinvestment in this area. And if you want reform, you want a bit of headroom to work with. We've certainly got to take the workforce with us, and at the moment there's been insufficient attention to the workforce and their morale, their needs, their training, their kind of aspirations. We are seeing, unfortunately, quite a lot of hemorrhage of the workforce at the moment. So that, I think absolutely has to change. Prevention, we completely agreed with, has to be there. And thinking about this primary, secondary, tertiary care prevention, improving diagnostic capabilities, particularly for the big ticket issues, I think is important. Working on that integration, we think it is important. It is the right direction of travel, but doing this within kind of realistic timeframes. And then, I think really important is thinking about the underlying informatics. That was the kind of previous discussion, and even more importantly, I think, are the data flows and really making your data as liquid as possible. I had the privilege for that Lancet Commission to lead on the kind of health IT and data science strand of that work. And one of the things that we're trying to propose for the UK is, can we turn the NHS into a genuine learning health system, where what we have are the data there available to think about this at a macro level, and that's the kind of discussion that we've got taking place at the moment to inform those policy deliberations, to allow sort of ongoing evaluation, informative ways, prioritisation, setting courses without kind of whole-scale sort of moves in sort of new directions. Premature abandonment sometimes. Really trying to drive forward organisational efficiency, benchmarking considerations, and I know there's kind of capabilities to do that within clusters in Singapore, but can we do that nationally? And then also really supporting that whole personalisation of care. So I think what we have is one of the things that the pandemic has taught us, and this has been, the data diagram for Scotland. So, for COVID, we have now real-time data capabilities. So I can link data on 940 GPs, so that's every GP in the country, together using our unique identifier with hospitalisation, mortality, prescribing, dispensing, census data, maternity, neonatal, vaccination, testing, sequencing. So what we've been able to do is, is really make absolutely fantastic scientific advances by developing this real-time capability. So the discussion I'm now in with government is, can we say that that was a kind of a proof of principle? What we now need to move to is, can we now deploy this in terms of whole system intelligence capability for a whole country? I think, there are I think very strong parallels with what Singapore might be able to achieve. So just in summary, I think the lessons that we're kind of learning are that, leadership is absolutely fundamental, but what we need is distributed leadership models that is kind of situationally aware. That then needs to be translated into a kind of a vision and a plan. For us, I think this is less of a consideration for you guys, but what we do need is kind of cross-party buy-in, because if we're just going to have changes taking place every couple of years, none of this is sustainable. What we then need to think about is alignment, and that's political, legal, financial, and underpinning informatics and data science capability to support all of that. I think sort of taking the workforce on the journey is absolutely fundamental. We've neglected that, and we are now paying the consequences, I hope. You don't do that. I think that's really important. Integration is a means to an end. I think we need to remember that. And I think the oil, to kind of quote, I think one of the metaphors that was being used earlier in the day are data. Can we make these as liquid as possible and make these as useful as possible to service all sorts of ends? I think we certainly have the potential to do this in Scotland and the UK. Whether we can translate that, that's what I'm trying to work on over the next decade. So I'm going to stop there. I hope that was of some help, and really looking forward to the discussion. So thanks very much indeed. Thank you.
Thank you, Prof. Sir Aziz, for your honest and insightful sharing. May I ask that you take a seat on stage while I invite up the moderator and panelists for the panel discussion on Partnership for a Sustainable Healthcare. Our moderator for this session is Dr. Kaur S.K., Chief Executive Officer of Angsana Health. Dr. Kaur specializes in health systems and global health, with appointments at Chatham House, the National University of Singapore, and the United Nations University. He is also the chair of the ASEAN Business Advisory Council Healthcare Working Group. Dr. Kaur will be joined by a team of distinguished panelists. They are Dr. Leong Chun Kit from Mission Medical Clinic, Professor Eugene Fidelis So, National Healthcare Group, and Dr. Mary Ann Sao, Sao Foundation. May we invite Dr. Kaur and the panelists up on stage, please. Now, once again, as they are walking up, I would like to invite everyone to key in your questions into Pigeonhole. Keep them coming. All right, and now that our panel is on stage, I will hand over the time to our moderator. Over to you, Dr. Kaur.
Mic test. With your permission, I'll take off my face mask. Good evening, everyone. This is the last panel for today, and because it's the last panel for today, my requests to the panelists earlier when we were convening is to, be a little bit more provocative and to be stimulating and to say things that they might not otherwise say. So in the spirit of Partnership for a Sustainable Healthcare, I would like to begin the panel by introducing them in turn just before they answer the first questions that we have for them. So the first question is actually to Professor Eugene Fidelis So, or Eugene as he prefers to be called. Eugene, the question goes like this. What are some of the best practices for sustainable partnerships in healthcare in the last 10 years and also in the next 10 years? Over to you, Eugene.
Well, thanks very much, SK, and thank you to my fellow panelists for today's discussion. I know it is the last session of the day, so everyone has gotten a lot from today's sessions, and I hope very much to be able to share just some personal perspectives about my learnings in trying to build our health system together. The first one is that I think having seen many health systems around the world, including the NHS, with various systems that are strengthening their primary care, for example, what they are doing in Alaska, and to what they are doing in Sweden, where they are really strengthening the whole community ownership around the care models. There are really very exciting models across our various health ecosystems that we can really learn from, and we can really put that together in terms of designing the best possible system to drive population health. Locally, I would say that the best practice I've seen is actually on my left. Professor Marian Sao has been actively at work building COMSA in Whampoa. What I like about it is its ownership of the community and its ability to outreach to residents and not just wait for them to fall ill and come to the system. And I think we need more systems like this where we can be a lot more proactive. And I think that the future of health systems will be about how we stack up the various care models that we have, all the way from the individual to the large population health systems that we want to co-design. So if we can stack it up correctly, then I think we get great alignment and we get great partnerships across the system to deliver health.
Thank you, Eugene, for kicking us off the conversation. And I'd like to pass the floor over to Dr. Chow for her comments in a second. As part of my brief introduction to Eugene, which I will not repeat from the bios that are available on the website, is to say that he grew up with the National Healthcare Group, present at his birth, present when it clustered, present when it declustered, and present today as well. So we should like a long and successful career in NHG. Dr. Chow, Eugene has mentioned that one of the best practices is actually the work that the Chow Foundation is doing in Singapore. Do you mind if you elaborate on some of the best practices that you have seen and some of the work of the Chow Foundation in Singapore? Over to you.
Thank you. Actually, thanks, Eugene, for your kind comments. Try. So I think just as Professor Aziz talked about the macro level policies and Eugene talked about systems, I'm a community practitioner, nonprofits. My comments come from a perspective from the community looking up. So very much at a micro level. I think generally speaking, in my very simplistic view of sustainable healthcare systems, simply people not having to use it very much, which means that if you're very healthy, that you won't have to consume a lot of healthcare, and particularly very expensive acute care. I would say, generally speaking, a focus has been investing a lot in the acute care sector, and then in the end of the day, encouraging people to use it, and end up people using it as a sort of the first stop and then stepping them down. And I think moving forward, the whole goal of I Think Healthy SG, and certainly I share that aspiration, is to keep people so healthy in the community that you prevent them from stepping up into acute care as much as possible. So therefore, in the effort, some of you may know I work with older people, and of course their needs are very vast, and oftentimes they're very complex. So for the last 5 years, I've been working very close with NHG and TED Talks in great partnership, and with the community to build a sort of pilot model whereby you integrate a healthcare, the primary care, with social care, because we all appreciate that social determines a great impact on how well people age and how well people stay healthy, and particularly for the older people who've already had many years of perhaps poor health and poor access to good health for whatever reasons. And of course, Dr. So knows, and then older people in the community, they don't come to a doctor voluntarily. You have to find them, cajole them, somehow bring them to primary care, to good care. So generally speaking, the model we developed is basically primary care with fairly wide range of practice. We try to aim for health promotion, early detection, regular acute care in the community. Hopefully we do better with health education for self-care, working with caregivers, so on and so forth, until the very frail ones. And then we hand them over to our home care team to take them on as they become more palliative and more end of life. But very much important actually is the social care part. But to talk about partnership is that one of the best things about partnership with NSG is that firstly with the polyclinics, because we're able to procure affordable drugs, because many of our older people are fairly low income. So if you have private practice costs, it's just too expensive for them. And that was a major coup. On top of it, we worked the polyclinics so that those who need more social care, one of the polyclinics referred to us. And with the hospitals, it's been great because when we admit someone get admitted to the hospital actually let us know. So we can trigger right away a reaction. We talk to the older person, the patient, the family, whoever we can get to talk to in the hospital to give more information, and hopefully to have early discharge planning. We follow up with them after discharge as quickly as possible, appropriately, to make sure they don't fall through the crack. So we try, and I wouldn't say it's working so well, it's a lot of operational glitches, but we try to practice something like that. And of course, on the social side, our care managers have to work very much with the other providers, the community, the neighbors, the people do outreach, of course, all the other social service providers that provides meals or whatever else, to build a sort of a more stable social structure around these older people with complex needs. So it's really combining medical care and really being part of the system of medical care as well as with the social care side. And moving forward, I think there'll be a lot more partnerships to do. I would love to see that, when patients our patients have to go to A&E, we can actually call ahead so they know who's coming, and so that they can actually, of course, A&E doctor have more information to work from, and if they don't need to be hospitalized, come back to us. And if they get admitted, of course, the same process will work. Will apply. And of course, particularly for older people, but say across the board, mental health is a major issue. All old people growing old. Mental health, we already now built up channels with IMH because we don't specialize in taking care of schizophrenia and all that. We need to work with specialists. Same thing with people with intellectual disability, with HIV, with drug addiction. All those people grow old. I mean, for us, perhaps specifically because we work with older people, we need to create partnerships with many institutions so together we can provide the care that the older person would need. Thank you.
Thank you, Dr. Chow. So you can see that healthcare, just from the short speech that Dr. Chow has provided, is very multi-stakeholder with primary care in the center. We'll turn to Dr. Leong Chun Kit to tell us a little bit about primary care. But before that, a short introduction to Dr. Chow that's not in the bio is to say that she started her career as a pediatrician in social medicine in the US. So she started with an extreme of age, and now she's on the other extreme of age right now. So thank you for working in the vulnerable communities, Dr. Chow. Dr. Leong, what are your thoughts about the role of primary care as a center, the coordinating center and the foundation of, shall we say, sustainable partnerships and the health system? What else is missing, for example, in the Singapore system in primary care? Over to you.
Thank you so much. Maybe I would like to start with an analogy. Partnership is a little bit about relationship, maybe a little bit deeper than that. So maybe use analogy of a boy-girl relationship, right? That might be better, right? Now, also, when somebody needs to build a relationship with one another, they need to know each other very well, right? Not only that, but also deeply involved in the family of the other side as well. So a GP being a busybody that we should be, right? We will actually try to know our patients and families very well. In fact, to many extent, including the extended family. Yeah. So that actually helped many of us to build relationship. That's one level of it. Now, another level of it is between the primary care and the partners. Partners meaning the specialists, even the social services. So for us who run primary care networks, we actually have access to social services through the AIC, what we call the IRMS, which is a referral system to the social services. So what we can do is that currently what we do basically is just, if I need a patient to be referred to the social services or to the specialist, we just fill up a form, make an appointment, and that's it. But very much of it actually also depends on the relationship between the professional. So I run a family medicine clinic as well in Tampines. So what we do very often is that we actually talk to the specialist handling the patient because it's a partnership between St. Andrews, ourselves, and Changi Hospital. So that is always a three-way talk, and we do have monthly meetings that we discuss about the patient, the families, and issues, because the patient was just going to daycare center upstairs, and they come down if they have problems. If no problem, sometimes they just come in for a check. So that kind of relationship is very important, because basically we have each other's handphone numbers, the specialists and ourselves. And it helps a lot because the other co-chair from Changi Hospital, the geriatrician, is actually my very good friends in medical school, right? So I think that why I wanted to use the relationship analogy is really because of trust, and on top of it, we have a structure. Just having trust and a relationship without structure doesn't make sense. And the third part of it is this relationship need time to grow and also to refine. A good relationship between a boy and a girl, after they get married, right? I'm sure we quarrel with our wives or your spouse, right? But you also make good after that, right? So similarly, in a kind of relationship like this, there will be differences in terms of managing the patient, I mean, I do not hide the fact that we quarreled with my friends in Changi, right? They say, oh, this patient shouldn't be managed this way. And they think us stupid GP, right? Do it this way. But we do have our point, right? What's the point of giving medicine when the patient do not eat it, right? So we sort of understand over years that how we operate because our environment is different. And that relationship grow and grow in terms of respect and so on. So I think moving forward, as we talk about sustainability in terms of partnership, it has to be a very moment by moment thing as we refine, as we work up our own relationship between the patient, between the specialists, between the different partners in social sector and all that. We really need to build that and refine it. Yeah, that's how I look at it.
Thank you, Dr. Leong. For telling us about the importance of partnerships being based on trust, on time, and also on the structures within the partnerships, not only between the patients and the doctors, but also between the partners themselves as well. Also very useful dating tips, Dr. Leong. To come back a little bit to Prof. Aziz, to mention, to go back to Prof. Aziz and your speech earlier, is to ask you the question, Prof. Aziz, about the differences between Singapore and the UK. Obviously, there are differences between both these countries in terms of the politics, the economics, and also the social contract. To what extent are, shall we say, the lessons and the best practices that you've described earlier in your speech be implementable in Singapore, given the differences? Over to you, Prof. Aziz.
Yes, I mean, I think there are a lot of similarities and differences, and I tried to highlight some of those in my presentation. I mean, you have a lot more political stability here than we unfortunately do at the moment in the UK, and I think that's certainly for us that's a really important bit of the context. We've had a very mature general practitioner-based health system that's been running for decades, and so I mean our GPs are all sort of postgraduate trained. That's kind of an essential prerequisite before they can practice. They moved from solo practitioners to working in group practices, I mean, probably 10 to 15 years ago. And I think that's been, so it's probably more akin to your polyclinic model than I mean, I know you've got a lot of solo practitioners, and I think that's a really important consideration. I mean, as it's just been discussed, the GPs being the anchor, the gatekeeper, the coordinator, they have very close relationships. There's continuity there. So I think there's a lot of strengths there to that could and should have been capitalized on. I think what's happened though with these current reforms is that because they are trusted providers, a lot of the care is shifted from hospitals. So this could be sort of investigative workups, for example, a lot of post-interventional sort of support, etc. And I think the primary care providers are very happy to do that, but the resources haven't followed. So sometimes, I think the government sees this as a kind of a cheaper model because it's a capitation-based model in general practice. And so the resources haven't followed and people feel overwhelmed in that respect. I think maybe sort of one other thing to mention in general practice that we have is it is now very, very multidisciplinary. So we have health visitors, midwives, psychologists, physiotherapists, dietitians, and that side of things I think is working exceptionally well. So I think the key thing at the moment for us is that the resources really need to follow. And I think overall what we also need to do is raise the profile and standing of general practice, because it is still seen as a kind of a poor cousin, and I think that's a similarity here in Singapore as well.
Thanks, Prof. Aziz. That's a very important point, that we talk a lot about the importance of primary care, and we consider it to be a more cost-efficient, affordable, maybe even cheaper model, and yet the resources don't follow. Let's build on that theme a little bit and ask the three panelists what their open thoughts are about this question. Maybe we can start with Dr. Leong. The question would sound like this. How can we empower primary care to become a stronger care coordinator to ensure that primary care gets the stature, prominence, and the funding that it deserves? Opportunity to make a speech.
All right. Maybe you start the ideal aspect first. Yeah. So in the ideal world, the GP forms the foundation of the system. So, like we all rightly say, actually, we are the coordinator of care. We are also the gatekeepers in that sense. Now, so let's start by talking about our daily practice. So the question now is that, are we doing this role currently? So unfortunately, the reality is we are not really doing that much of it. Yeah, there are many reasons to this. Of course, the first thing is that the patient may not choose us to do it. As we are aware, Singapore is a very small place. People have direct access to the specialists or even allied health and all that. Sometimes they just bypass us. And so we sort of miss that opportunity. So within the private GP as well, for example, if we were running a very busy clinic, my practice is a little bit different because I go by appointment system. I see very few patients per session, probably 10 patients in the morning. But some GP clinics are very busy. They are seeing 50 to 60 in the morning. There's almost no time to do coordination. There is no time to do even gatekeeping for that matter. Sometimes it's something that they could have done easily, for example, even ear syringing or a small procedure just to drain an abscess. They may just conveniently refer out. It's a lot easier just to write a referral letter that takes 3 minutes, right, or 2 minutes to write that and refer out, rather than they do it themselves. So we sort of miss the opportunity ourselves because of all these factors, the patient's factor, even the GP ourselves. So unfortunately, I think when we move forward to a capitation model, Healthy SG, we ourselves need to so-called back up a little bit, right, to do that, to remind ourselves that that is our role. The next step is, of course, training. In terms of training, we do have a very strong training system in Singapore. But yet, it's a bit like what Prof. Aziz said about resourcing. Now, so the moment we have finished our postgraduate, either MEd or whatever, fellowship and all that, when we go out to our own clinic to practice, patients do not pay us according to our training, right? They just pay us according to what they want out from us. Yeah, that sort of defeat the purpose as well. So the training part is not the issue, but the whole thing is that, are we going to be able to practice what we are trained for? I think that part we also need to address. But I think in Healthy SG, these are good news because this is the time to talk about resources, talk about resourcing and how we reshape the system. Now, then again, there's a next level where we talk about referring to the allied health services, not only the specialists, but the allied health services. So a lot of times in Singapore, currently our GPs are mainly solo practitioner. So solo including those that are 2 or 3 man practice. Essentially, we are still solo, like parked in the same place, rather than a multi-doctor practice where overseas, where people sort of leverage on each other's strength, right? So that kind of system is not very ideal when you talk about referring or gatekeeping, or even for coordinating of care. There's no space for the allied health, for example. You probably need at least one center of which in a precinct, a bit like what Dr. Chow, you have it in your Wongpu area, a little bit in a one-stop kind of center, but are we able to do that? Now, so I think looking forward again, this is something that if it is possible, then it will be very ideal for coordinating as well as gatekeeping. Now, of course, the last one is the specialist care. But sometimes we need to talk to the specialist. In Singapore, our problem is when we refer a patient, whether it's private sector or the public sector, a lot of times the specialists don't talk to us. Some don't even refer back the patients to us. And that is a problem. How do you do coordinating of care or gatekeeping when the patient don't come back to us or there's no feedback to us what is happening? So all these things need to be sorted out. And I believe that Healthy SG is the answer. Yeah, I hope I'm correct.
Thanks, Dr. Leong, for your input about how we can get primary care, a bit more stature, a bit more prominence, and a little bit more funding. Eugene, if I may, the same question to you as well. What are your thoughts about how we can get more stature, funding, and prominence for primary care?
I think primary care is an important cornerstone for how we will design a population health system. But a very strong cornerstone will require many other stones to build an entire system work. And in that regard, I think the shift in primary care is what Dr. Leong has mentioned, that we do need to shift away from a chief complaint basis of assessing primary care to a more relational model in primary care, where the relationship is about that care goals with the patient and what we're trying to achieve. Today is largely chief complaint based. And therefore, the relationship seldom get built up. And therefore, in some ways, not sustainable as a strong model. And I think the tenet of family medicine is really looking after not just the individual, but the family around him. And if we can strengthen that relationship model, I think this cornerstone will be a very strong one for the entire system. But that is not enough, and that's where I will go to Dr. Sao to say that we need to wrap around that relationship with a strong place-based model of care that will integrate health and social care. Because these two aspects of care cannot be devolved. Healthcare has longest time been the safety net for where there are troubles at home and where there are social issues, and they come into our health systems, all right, be it manifested through addictions, poor health or disability, they come in. So if that is going to be the driver, and if we are going to succeed in building this bridge between health and social care, then I think the wrap-around care is going to be really important, because the GP can't solve all of it himself. Today, the fragmentation of healthcare is not just between the hospital and primary care, it's also between primary care and community care. So if you want to bring that all together, then that is where the third layer around the community care will be strong integrated care models. Because that is where you fall into that travelator that Phillips talks about, and you do need a care journey sort of mental model to string together what would be important to address your care needs for that particular patient. So I think if you add these three models together, the challenge to us as a health system is how can we bring that together? How can we align the resources and the payment models that will enable that to occur? And ultimately, what is that common language that brings us together must be the health of that individual that will be co-owned with the community around him. And I think that is where the sweet spot will be.
Thank you, Eugene. That's a great segue to go to Dr. Chow and to ask her thoughts about the social sector and or primary care, if you would like to discuss that, Dr. Chow.
I kind of think of, maybe it's my social medicine background, I think of a health provider, doctor, nurse, team, whatever, as sort of a health buddy. You travel their life together. I suppose maybe because I started as a pediatrician, you start talking to parents and mother before when they're just pregnant. When a baby comes, it could be a healthy baby or a baby with heart disease, whatever they may, you'll walk with them throughout until they're 21, and then hand them over to somebody else. So some of my kids, when I was practicing, didn't want to leave. At 21, you've got to go. But I think it's that journey, and you have that relationship, and they trust you. And that trust is very valuable and precious and big responsibility, but oftentimes care just goes so much smoother because that trust is there. And it takes time to build that. Takes time to build. So, I think when I think about the health buddy, of course, I like to think of myself being the first contact. So whatever problem you may have, you come with me first. You don't go see the skin doctor or see the whatever specialist. You come to us first. Because most of the time, we can handle pretty much everything, right? And then you provide that continuity so you know each other. For older patients in particular, they're complex. They have a life. How they cope with a chronic diseases depends on who they are as a person and how well you know them well enough to motivate them, help them be able to do good self-care. Again, very much understanding that person, understand the resource they may or may not have, and how to support them. And so oftentimes it's that continuity that's very important, because they know you, you know them, trust are there, and also because you know what they can and cannot do. And of course, the comprehensiveness is important too, right? You take care of everything. And we routinely discharge that patient from specialist clinic because they really don't need to go. Even for people with dementia, we can handle most of that. And that's another thing that's great with partnerships, that we really need care, like some kind of consultation. We call up our geriatricians, and we don't have to send them to geriatric or dementia clinic because we can just get a consultation online and send them only where we need to. So the comprehensiveness means that I can be there for pretty much everything you need. I'll refer if I need it, but everything else I can take care of. And then, but beyond the comprehensiveness is the care management, right? They have needs other than the medical bit. They have the family thing, the social thing. So of course, the doctors just do all. We use our nurses and social workers as well. But that the care, managing the cluster of care, the total care plan, it's not just the patient. Sometimes it's all a social thing. And sometimes that increasing practice family-centric care because it comes with the caregiver. If we don't deal with them, they can't provide a care either. So, so I think that care management and the coordination, again, are very much important to help them, because if you don't help them coordinate, they don't end up in the care they need to go. Because it's too difficult for them to navigate a health system sometimes, so we have to make it easy for them. And on top of it, like I said, there's a mental health bit, so you have to pay attention to the care and counseling bit and refer appropriately and support them when we need. And of course, early detection of issues like anxiety, depression, we have to be very tuned into that. And on top of that, older people's suicide rate is quite high in Singapore as in elsewhere. So everyone's better trained to detect any kind of those tendencies, some suicidal thoughts, and be quick in picking them up. So the focus on mental health also becomes very important. So beyond that is that, you have to communicate. You have to make sure everyone who needs to know knows, whether the patient, the family, or specialists that are working with them, or whoever else. You need to communicate. And ultimately, as Eugene was saying, the community, we have to take a community orientation. So when we first went to this area, Whampoa, we did a little survey, about 25% of the population. We found that half of them are socially isolated, and about 10% have dementia. So we better beef up our ability to deal with those in our practice, because we'll see a lot of them. And when our community outreach colleagues are doing their job, they would be bringing them in. So better know how to deal with the people with dementia, how to deal with people with social isolated, or with depression, anxiety, so on and so forth. So even though you are just practicing in our little office, but you have to be part of that community. You need to know not just your patient and the family, but who this community is and what their needs are. So I think to practice all that, do we get paid for it sufficiently? No. Because it takes time to talk to people. It's relational. We always expect to see a lot of patients, but you're not able to really get value out of it. We expect to turn patient over every 5 minutes or 10 minutes, but the payment is not quite there. So for instance, we have the CHART system that pays, by June, they run out of money. Because they don't have enough to pay for. Already, my older patients take multiple drugs, they have more diagnostic, they come to clinic more often. Just isn't enough. So I think that the investment in primary care is really a must.
Thank you, Dr. Chow. If the audience can see the topic on the screen on top of you, it says Partnership for a Sustainable Healthcare. So the theme of partnership has already given us two very important sub-themes to talk about: trust, relationships, time, spending the time to build that relationship over a long period of time, right? So that's one theme. The second theme is about aligned incentives, and we'll talk about that shortly as well. Dr. Chow, if it's okay with you, I'd still like to stay with you a little bit, because there's still a lot of because there's a lot of interest here about the social sector, the third sector, civil societies, NGOs, foundations, philanthropies, to use Eugene's word, the wraparound system. So not just hospitals and clinics, but also the community. The question from the audience is this: how might the social sector also take a leadership role? My addition to that statement, to that question, would be: how can civil societies like the Child Foundation position yourselves to play a greater role in sustainable healthcare beyond just donor funding? Over to you, Dr. Chow.
Right. I think donors, I wear the other hat from my family side foundation. So the donors must also be well-informed, and I think that there are a lot of innovations that could be supported by philanthropic dollars. For instance, self-care. I think generally speaking, the best patient to have is a patient who knows how to take care of themselves. Right? So I think focus on self-care is so important, but they have to have the literacy, the sort of health literacy, as well as the support around them to really change. We don't focus enough on that, I think, on the systematic level. And I think with Healthy SG definitely has to come. It may not be the physician, because it's really expensive to do that, but health coaches, health educators, all those can actually be funded actually as actually, government should probably help to fund those too, but never mind. I think in terms of piloting things, I think the nonprofit, the philanthropic sector can do, because this is where foundation philanthropies can take that risk. You don't want to spend public dollar on on experimenting things that may not work. And I think that's one of the biggest values actually when philanthropic dollars be spent on these pilots to test different models and see if it works. If it's worked, it could be adapted and adopted widely or scaled, but if not, then never mind, it's an experiment. I think the ministries also fund some pilots, but I think there could be many more smaller, small size, big size, whatever kind of innovations that the philanthropist can provide. But if the philanthropist doesn't know enough, they won't be able to give the grant call that makes sense. Whether it's self-care, whether it's building community, whether it's educating community about, like for instance, a huge amount of myth and stigma around dementia. So for us to outreach to people with dementia, it's like tremendously difficult because they don't want to know about it. Even if I know that someone with a household with dementia, family doesn't want to know about it. So I think that there's a lot of work that we done to make the community more self-aware, better informed, more motivated. And that kind of stuff we don't do enough. And I think the philanthropic dollar could do a lot in terms of promoting that kind of experiments.
Thank you, Dr. Chow. Can I open the same question to the panelists? Eugene, you might want to say something about the social sector and how to bring them in your work as a Deputy Group CEO.
Oh, I was going to kind of pick up on one of the points that Marianne mentioned earlier on, which is, where's the money coming from, right, for health and social care. And we have one-payer systems like in the NHS, and we have this majority of different systems in countries like Singapore, where you have tax-based subvention, you have our pension fund, and you also have out-of-pocket employer payments. The question, if we were to do good health and social care, for me is how do we bring the payers together to have a conversation around what matters in that community. And often than not, you will see everyone planning their own mental models of how that is. So you don't get this idea of one population, one budget. You get this idea of one population, but different budgets, different components, and the alignment is very tricky. And I think if we were to take a more generous approach to how we look at the community ownership of health, the UK has experimented with quite a few models there. The challenge is always that even if you can bring that budget together, the big question next is then how do you distribute it? And that becomes a challenge because there's so many needs and there must be some sort of a locative mental model in your head. So Samuel Gray from the NHS talks about allocative value as a component that not everything cost-effective is worth doing. We have to choose what is most important. But that makes health no more an individual good, it makes it a collective good. Now, if you look at the whole idea of population health, what we have not talked about as a society is to talk about what is that collective good that we want for society, our health. In Singapore, at least, a lot of focus is on individual health. You know, your chronic disease indicators, whether you go for screening, whether you have your vaccinations, which points to a common good, but yet very much focused on today individuals. But if we were to look at that broader thing, I think then we can bring civil society together to better own this collective good. And for me, that is the key ingredient that is missing in today's conversation on Healthier SG. And I remind people that the definition of population health is not just better health outcomes, but it is also about the distribution of that outcome. We are not talking about the vulnerable populations in our society, the 15% that's unreached by our health system, that we don't even know who they are or what their health status is, that we need to use this mechanism to uplift that community support and model. And I think that is where the big challenge in population health is whether we collectively want health, not just for the individual, but health for everyone.
Thank you, Eugene. Appreciate the conversation about pooling resources and also allocating the resources in ways that are truly fighting inequality and making sure that you achieve the outcomes of health for all, not just health for a collection of individuals. Thank you for that. If we can return briefly to the topic about bringing the social sector, then we'll close that and we'll move on to talking about incentives and resources. Prof. Aziz and Dr. Leong, do you have any thoughts about how we can bring the social sector in, the third sector, and combine and integrate health and the social services? Over to the both of you.
Yeah, I mean, so I think this is very important. I mean, an obvious way this plays out is in terms of kind of step-down facilities, because this is, I mean, a major reason why people, for example, in the UK, I mean, are struggling to be discharged. I mean, they're kept in hospital for longer than they are needed. What we need to do is to bring that social care budget within that same kind of budgetary envelope and then think about, I mean, appropriate distributive mechanisms. So that's kind of a work in progress. The previous Prime Minister was, I mean, I think working on that, but he's now been displaced. And there's been sort of, I mean, major kind of political rollback from the new incumbent. So, I mean, this is, I mean, it's kind of very challenging. I think maybe the wider question around, I mean, these partnerships, I think there are kind of very major gains to be had at population level if we just think a bit more laterally. So, I mean, I think partnerships with, for example, supermarkets, the food industry, and that was touched on earlier this morning. I think that we can go so much further in that respect, because I think individual responsibility, individual kind of good intentions go so far when you're confronted with sort of, I mean, then choices and discounts and, I mean, all those kind of incentive mechanisms that, I mean, are kind of counteracting that. I mean, yeah, I mean, individual sort of motivation and intention, I mean, often get thrown out of the window. So, I mean, I think there are much more creative partnerships. I think in the work sector, for example, I mean, how do we actually, I mean, create sort of health promoting work environments? How do we give people time off or kind of incentivize healthy behaviors? I know, I mean, other countries are looking at shorter working weeks, for example, to deal with, I mean, some of the stresses that, I mean, again, were being discussed this morning about how we can reduce some of those. And I think many of our countries are plagued with mental health problems. So I think there's kind of a lot more creativity, I mean, in this space. Much of it needs to be evaluated, but we think it needs to be thinking, because, I mean, healthcare and social care, they're important, but when we're looking at sort of population level health outcomes, they're marginal players, really. It's that wider environment which is much more important.
Thank you for helping us think outside of the box. Dr. Leong.
Okay, so maybe I would like to offer a little bit from the primary care perspective in this. Definitely, I think that we all, if we dig deep enough with our patients, we realize actually the patient is not just a sick person or a case, right? So there's a lot of interaction between them and the family members and the social environment around them, right? So actually, one of the things that I've done is a few years ago, I founded a cooperative. Yeah, so the whole idea is similar to what you mentioned. So sometimes it's very difficult to get public funding for pilots and all that, and there's very little autonomy if you get public funding. So what we have done is that we gather groups of GPs as well as specialists, allied health, and so on. And one of the things that we suddenly realized is that we actually have not included a lot of the social service sector. And one of the projects we did was actually to prevent suicide and mental health. So we were talking to some psychologists, bringing them in because they're allied health. Then suddenly we realized that a lot of the stressors faced by our patients actually are not just pure medical. The family actually created a lot of stress for whatever reason. It could be relationship between mother-in-laws and mother, the children, the employers, and all that. And so we realized actually we need to bring in the family service center. And in fact, today, we call it ecosystem in our cooperative. So the mental health cooperative, actually, we have various group of people, including the social service representative, social workers, counselors, some of them working in organizations that are supporting special needs children, special needs adults as well. So it became an ecosystem where we talk and we advocate things. In fact, sometimes we challenge each other to mention things in the public sector, public space, for example, right to Straits Time Forum about certain things, you know. So we actually advocated a lot of things. And then as a cooperative at the back, we are like playing like a conductor playing in the orchestra. So that's how we try piloting different things. And so in the PCN that I run, in the primary care network that I run, today in our practice, so the moment we see somebody who is depressed or have anxiety issues, we have actually a link to do a PHQ-9 and a GAD-7, and at the back it's read by the social workers actually. Yeah, and then they will not only tell us whether they are anxious, whether they are depressed, but also the dynamics at home, including, for example, I had a girl who is doing her O-levels this year, and we assume that because she's stressed by her results and all that, but the social worker is able to tease out some of the very sensitive things at home, how the parents were expecting her certain things, and that created the stress more than the exams and the results. So I think this kind of model as primary care GPs, I think we need to be a bit more busybody. We need to look into more of this. And we also need to know more about the social sectors. So it's not just the suicidal ones, not those the elderly dementia also. I mean, those are included. But as simple as where to get meals for some of the old folks who are single and growing older, the frail, those who are, in fact, the other group that I'm very concerned about is actually the special needs that are growing older in their 40s and 50s, where their parents are also growing older. They probably will outlive their parents. And these are the groups that people, we doctors, I don't think we can do very much, but we can definitely play the coordinating role if we know the social sector service a lot better together with the voluntary welfare groups. I think this is something that the role a GP should go into when we talk about healthy SG.
Thank you. Here's a short partial summary of the richness of the content so far. Firstly, the best doctor gives the least medicine. Maybe that's something we should all consider. Secondly, the Japanese model is not called the Ministry of Health. It's called the Ministry of Health, Labour and Welfare, all in one. To Eugene's point about pooling resources, to Prof. Aziz's point about partnering innovatively and outside the box, and to Dr. Xiao's points about partnering to the social sector as well. So I would like to, because we live in a democracy in Singapore, Malaysia, where I'm from, always a democracy. There have been audience voting for the questions. I'd like to go to some of the audience questions. We've already discussed some of them. I've already marked some of them as answered. Let's go to one audience question about aligned incentives. And this is the one that I'm going to put on the screen and make it active right now. Hopefully we can see it. Let me read this, okay? Thank you for this question. Often, and I read, often community care partners and primary care and acute care have varying KPIs or key performance indicators, and funding is also very different. Under Healthier SG, how can partners work together even if their KPIs are not aligned? Or if I'm going to flip the question, how can partners align their KPIs? What best practices might you suggest to the audience that when they are building innovative and sustainable partnerships with people outside the NHG, I'm thinking that most of you are from the NHG, how can we align the incentives with partners who are outside the NHG? Maybe it's an open floor to any of the panelists to get started. Perhaps Eugene to kick us off. Sorry to put you on the spot.
It's a huge challenge, isn't it? Because you're talking about a whole of system sort of transformation and change to bring everyone on board this journey for Healthier SG. I would say that I don't think everyone needs the same KPIs. I think we need to understand what is our role in this transformation and how can we contribute to that role and make it a whole. So the conversations for me are definitely much more important than the fact that you have a KPI. And if we can bring the conversations together, this is kind of, it's kind of like a mess, right? Healthcare and social care is not just input and an output sort of linear dimension, but it's kind of this complex adaptive system that we are all trying to figure out. And so I like to say that it's a gooey mess, right? So how do you make the glue stick together such that the mass holds, but you can stretch it in different ways and that you are able to create a network out of it? Today, when we call a network, we mean by and large bilateral transactions and interactions. So a hospital works with GP or a community provider works with the hospital. So we talk about such mental models. But if we were to go out there and we bring together this gooiness in the mess, then I go back to Dr. Leong's first point, that fundamental to the whole transformation and change is the deeper learning that is more relational in nature, rather than it is the KPI about system excellence and output. So if we can build that into the ecosystem, then I do think that we will do what is right for the patient. And by doing what is right for the patient, we shift the paradigm about where more is better to where better is more. So today is a Tai Chi system. Basically, I cannot manage Tai Chi to you, Tai Chi to me, and we keep passing the buck around. And you know, the patient may go through the entire ecosystem, but he could be none the better compared to the first referral that he's given. And I think we need to be able to change and flip that around. And I do think value is going to be a strong and powerful alignment language to bring together this relationship. But remember, it is not everyone delivering the same value. It is how we can contribute to that patient's health and how can we sustain his health such that he doesn't become a ping pong being passed around the system.
Yeah, I agree with Dr. So. So first of all, the KPI, even if we have forced to create some, right, it has to be developed together. I think that's important, and especially with the focus on the patient. So whether it's social, whether it's primary care. I also believe that when we talk about incentive, too much incentive actually will drive us crazy, right? Yeah, it's tempting, right? Now, too little incentive is bad too, because I believe it creates evil, right? Yeah, a lot of this evil, especially for doctors, I'm sure we can do things under the table, you can't see it, until maybe decades later you picked it up. Yeah, so we are clever enough to do that kind of thing, but that's not good for the society. So I think that even incentives, when you talk about incentive, it must be a collaborative way. That means it must be, like what Dr. So said, it must be one that we come up together, sit down and talk, and then figure out what is the sweet spot without tempting, without getting people to go into the evil way of actually, just hitting the KPI. I'm very worried about that, actually. Yeah.
Dr. Chow, Professors?
Well, actually, I think the issue of incentive is interesting because from a healthcare provider's point of view, whether a healthcare or social care provider, ultimately it's really the well-being of the person or the family we're dealing with. So that's ultimately the goal, not the KPI it is, right? We're chasing KPI, we get lost in that. And it's really important that we don't forget why we exist in the first place is not to do KPIs, even that is part of reality. And sometimes also the communication feedback, when KPIs don't make sense, we have to kind of push back, right? But I think one incentive is important for the people using the health services. What would incentivize them to use it appropriately and what would incentivize them not to? I think to me it's the flip side. The patient also has choice. So we think a lot about incentives for providers. We also have to think about what does incentivize patients to come. One of the key things that's a little bit perverse is that it's cheaper to go to a hospital than they're not, right? So it's easier to leave from the hospital. So from a patient's point of view, they have their thinking too. So I think that whatever motivates, incentivizes providers to work together must always remember that you are working with patients who have their own thinking, own way of responding, their own perspectives, and that must also align. Yeah, so I just wanted to bring that point up.
Thank you, Dr. Chow.
Yeah, I think I kind of largely agree with what's already been mentioned. I think in terms of, the goals that are trying to be achieved, they ideally need to be co-created, and metrics are important, and they don't have to be the same for everyone. But I think, having relatively few of these that are meaningful, that everybody's invested in, and understanding why they're there, I think is also important. And then people can support each other in terms of different sectors, different actors in terms of trying to achieve those. I think that co-creation piece is vitally important. One of the things, one of the kind of stakeholders that seems slightly to be missing from the conversation are the patients and carers, and I think getting their perspectives on all of this is absolutely vital, because ultimately that's why we're doing all of this, I think.
Thanks, Professor, for reminding us, and Dr. Chow as well, that the patient, the person, not even the patient, is actually at the center of all this. So to summarize the conversation about KPIs, they are helpful, but we might lose the patient and the human being in the process. Number two, they can be aligned, but certainly not identical. Thirdly, let's be guided by the value that we bring to the table and the values that we bring to the table as well. And values are different. And fourthly, we should co-create any KPIs and shared incentives together. This seems to be a reasonable framework for us to approach the issue of incentives. Let me pause here and say that we've got 8 more minutes in this panel. I hope that's it's been good for everyone. In the remaining 8 minutes, I'd like to offer the panel a choice. The choice would be for you to deliver 2-3 minutes of closing remarks, just about partnerships for sustainable healthcare, your closing remarks, or you can choose to answer the question with the highest number of votes, 87 votes. The question is, could you discuss possible ways to overcome challenges for Singapore's health system, considering the perspective of stewardship, or resource generation, or financing, or services? Let's remove the word and replace it with or, okay? Because each of these verticals are actually very important. So you can answer this question, or you can just share your closing remarks. I would like to invite Prof. Aziz to go first, then Dr. Chow, then Dr. Leong, and finally to close with Professor Eugene So as the host.
Yeah, maybe I'll just kind of offer a few final thoughts. I've kind of thoroughly enjoyed this visit here. I think you're embarking on something that we can all get behind. It's absolutely fantastic. It matters not only to Singapore, but I think the rest of the world. What I'd be inclined to do is think about these as kind of natural political experiments. We don't know whether this is going to work or not, but what we shouldn't do is wait till sort of 5 or 10 years have elapsed. It would be really helpful to be thinking about this, evaluating this formatively, to seeing, if things are on the right course or not. Taking stock, moving, shifting a bit, if at all possible. And I think if you do that, you not only help yourselves, but I think you help, many others who are kind of grappling with these really important questions about how do we move our health systems from these kind of reactive models to longitudinal models of care that are much more sort of preemptive. I think I'm really interested to see how this plays out, and thank you.
Thank you, Professor. Dr. Chow?
I was just thinking again from the people's point of view. Healthcare providers can think so hard to provide a perfect system, kind of get people to use it. But ultimately, I think society and individuals must take responsibility for their care. And I think as much as we have to build a strategy for very strong and sustainable healthcare, we also have the same strategy to see how we can build health literacy and motivation for individuals and families and communities to take charge of their health. And that could be in many different ways. Like for instance, it reminded me about something with schools. Someone reminded me recently in Hong Kong, people used to litter a lot. And finally they cleaned up because they educated students, the schools, to not litter, and they're the ones who tell their parents you shouldn't litter. So, I'm just saying that there are many different ways of changing people's behavior. I think we should put equal amount of effort in thinking and develop strategies to help get people to get themselves organized into the self-care. Because there's only so much care can provide, and it'll be very expensive. So people must also want to be incentivized and motivated to care of themselves. And of course, you have to segmentize the population, the little ones, the mothers, the older people, whatever, and have strategies. And I think that strategy has to come from different ways, whether through companies, what companies do for the middle-aged, the working age, community groups, who can reach out to the vulnerable groups, schools with the kids. It has to be a national consciousness, kind of consistent national consciousness campaign to get Singaporeans also to take charge of their own care. So we have to put, I think, a lot of effort to doing that as well. Otherwise, the care is always just responding to people who may not be doing what they need to do to prevent themselves from getting sick.
Thank you, Dr. Chow. To turn the patient from a passive recipient of services to become an active participant in health, right? Thank you. Dr. Leong, over to you.
Okay, I'll choose to do both. Basically, when I first heard about the whole idea of Healthy SG, I feel that this is a timely project. Yeah, that is not just good for the profession. When I say profession, I don't mean just primary care, but the whole healthcare system. But actually, it's good for the whole country and society. As we know that medical inflation is really very high, it's at least 10 times higher than our normal inflation, right? So I think it's very unsustainable. Now, I feel that this is an opportunity that all of us, whether we are in the allied health, social services, or primary care, or specialist care, this is something that we should take up and rally ourselves together and to make sure this system works. The other thing that I thought very urgently needed is actually to raise the health literacy of our people. Unfortunately, Singapore may be a very highly educated society, but the health literacy among our patients is actually very, very low. Even in our own practice, almost daily, we are trying to educate patients, trying to explain things they read from the internet and social media, which is, in some sense, is quite laughable and totally illogical, but to the patient, that is real, right? So in this whole project, I feel that we sort of left out the stakeholders, the main stakeholders were the patients, including the well patients. So we need to help them to understand the importance of Healthy SG in order to move forward. In fact, the thing that I worry about Healthy SG is that we overemphasize the primary care importance. Yes, it is a foundational piece, but yet we don't want to overshadow and become the front and forgetting the other stakeholders, especially the patient. I'm really mindful of that. I think that in itself, we will actually make and break this thing. In fact, there are other smaller partners that we need to bring in. So that include the other commercial partners like the farmers and all that. So these are people that is totally forgotten in the system.
Thanks, Dr. Leong. Professor.
Well, thanks very much for really a very engaging dialogue. I learned a lot from my panelists as well, and it has been really helpful in our own development of our healthier SG. I think there are many challenges. You know it, I know it, right? Manpower, cost, poor health outcomes. We're all tackling this, and it's a bit uncanny because all over the world, every health system are probably facing the same three big challenges. What is unique in Singapore is that we start off on a very strong basis where we have had good public health in Singapore, where the social determinants of health, the traditional ones like sanitation, housing, transportation, even standard of living, has been fairly well catered for in comparison to many other countries. But what we have with an aging population is that there is a change of new social drivers of health, right? The issues of frailty, the issues of dementia, the issues of social isolation. And these are tough issues that the health system alone cannot respond to. And we need a more collective approach to this. And we need the agencies in the people sector, the public sector, the private sector to come together to make this possible. And that is why the change is one that requires strong partnerships at the anchor of it. And I hope to work very closely with everyone here, as well as I like to say, this is probably the last white paper I will see in my lifetime. So I better make best use of it because the last one was written 30 years ago. So I guess the next one is 30 years later. And if you look at the opportunity we have now to change our health system for population health, I think let's not waste this opportunity.
And that's a great place to end this particular panel. The timing, the unique timing that's afforded to us by COVID, strong political will and political skill by the leaders in Singapore and also neighboring countries. We'll do our best with partnerships for sustainable healthcare. Ladies and gentlemen, Professor Sir Aziz Sheikh, Dr. Leong Chun Kit, Professor Eugene Fidelis So, and Dr. Mary Ann Chow. Thank you.
All right, thank you everyone for the very fruitful discussion. May I ask that you remain on stage for group photograph? Maybe you can just, all of you can step forward and stand closer to each other and we'll pose for the photographer. Thank you. All right, thank you very much. So thank you, Dr. Cole and panelists. Please return to your table as we are wrapping up for the last session for today. All right. Before we pause the transmission, I would like to remind our on-site audience and online participants that session 1 of day 2 starts at 8:50 a.m. So do remember to bring back all your personal belongings and the Congress back. A huge thanks.